of Florida.
I was just thinking, how are things in Florida?
Yeah. Right?
All right. So I'm going to ask you guys to start finding your way to your seats. And I tend to be a little bit of a planner. Like, I'm not as organized as I'd like to be, but I try to plan. So I'm just asking, I know the conference is over at 5:45. I also acknowledge that people have planes to catch or drinks to drink. But I'd love it if at least some of you could plan on staying just a little bit after. I know after my crying spell at lunch, that a lot of people are wondering what they can do, how to support. We'll have a little more information even than what I shared at lunch of different ways you can support, and also my attempt at a gift for Rajam, who may or may not show her face again. She doesn't like attention, but I have kind of an idea of a little something that we could give to her that she can do with what she will whenever she feels comfortable. So just if you can spare a couple moments, I would really appreciate it. So thank you for listening to that. And now I will introduce our next speaker, Meryl Alappattu. Dr. Alappattu has completed her Ph.D. in rehabilitation science at UF in 2014 and a postdoctoral fellowship at the UF Pain Research and Intervention Center of Excellence. She is currently a research assistant professor in the UF Department of Physical Therapy. Her research is focused on the mechanisms underpinning pelvic pain conditions in women and the prevalence and impact of musculoskeletal pain and sexual dysfunction following gender-affirming surgery. Dr. Alappattu serves on the board of directors for the International Pelvic Pain Society and chairs its Scientific Abstracts Committee and Ethics, Equality, and Professionalism Committee. So welcome, Meryl.
Thank you. Thanks, everyone, for being here. Day 3, end of the day. Appreciate everyone sticking it out. And thank you to Rajam for the invitation to speak here today. Again, my name is Meryl. I'm a physical therapist, and I'm a pain researcher at the University of Florida. And trust me, the irony from being from the state of Florida presenting on this topic is not lost on me, okay? So, but it's a topic that I'm very passionate about, and it's an important topic, not just for physical therapists and rehab providers, but for healthcare providers in general. So, as we get started, I want to just have a few disclosures. I do have some grant funding, and then as Sarah said, I'm on the board of directors for the IPPS. So let's start first by defining some terms. We have 2 terms, sex and gender. Back in 1993, the NIH mandated that NIH-funded researchers had to study women in addition to men. Before that, primarily men were those involved in clinical trials and these types of studies. So mandated that women had to be included as well. In 2001, so less than 10 years later, the Institute of Medicine, which is now part of the National Academy of Medicine, commissioned a task force or committee to look at whether it mattered, whether studying the biology of women mattered. Did we need to study the biology of women in addition to men? And what they concluded that the health status of men and women was not just impacted by their biology, but also by the sociocultural and psychological experiences of being a man or a woman. And so since 2001, they had that, their report from that committee has recommended that we have 2 different terms that we use, right? Sex, which is related largely to reproductive anatomy, to our genetics, hormones, physiology, versus gender, which is related to our identity, sociocultural roles that we hold, relations that exist, and also power differential that exists. So sex and gender are completely different, are different terms. When I say the term cisgender, what I mean by that is someone whose sex assigned to them at birth matches their identity. I flip that around. Someone whose gender identity, matches the sex assigned to them at birth. Someone who's transgender does not match, the gender identity does not match the sex assigned to them at birth. And so there's a term called gender dysphoria. The American Psychiatric Association has defined this as psychological distress that results from an incongruence or a conflict between one's sex assigned at birth and one's gender identity. The World Health Organization also has a term called gender incongruence. So it's very similar to this, but it does not have the presence of psychological distress. And so I think it's important to note that not all transgender people feel or experience psychological distress simply because of this incongruence or this conflict between the sex assigned at birth and their gender identity. So then this brings us to the question of how is this treated? So the big thing that you hear about in the news and media is surgery, but in reality, there are several different types of gender confirming care or gender affirming care. I'm going to use the term confirming care for this talk, but the first type of confirming care is social confirmation. So this might include changing one's chosen name, the pronouns that they use, modifying what they wear, their hairstyle, their voice. Legal confirmation would include updating any official documentation that they have, so driver's license, passport, that kind of thing. And then medical confirmation largely fall under two categories, which is hormone therapy and surgery. And surgery is where my work to date has focused and what I'm going to be speaking about today. So there are two sort of broad categories of surgeries. There's top surgeries and bottom surgeries. And I have quotations. They're referred to as feminizing and masculinizing surgery. But keep in mind that not everyone who undergoes this surgery or surgeries does it for the purpose of transitioning from a man to a woman or as a woman to a man. Some people, their gender identity is that they're non-binary. They don't identify as being a man or a woman. And so some people undergo these surgeries or surgery to affirm that gender identity of non-binary. So feminizing breast augmentation, masculinizing surgery is reduction mammoplasty, bottom surgeries, again, we have feminizing group and masculinizing group. I'm not going to go into a lot of detail about these surgeries. If you have questions about how you can get more information about these surgeries, Alex Hill, who's on this, who actually developed this slide, and a lot of other providers do some really great work in these areas, teaching other healthcare providers about how to help address some of these issues in patients following these surgeries. So why study musculoskeletal pain and pelvic floor dysfunction following gender-confirming surgery? So again, my background is a physical therapist. I work primarily in cancer rehabilitation and pelvic health rehab. And so coming into this, that's my background coming into this. We published a scoping review at the end of last year that looked at what type of literature is out there in terms of outcomes related to gender-confirming surgery. And with the exception of post-surgical complications, there wasn't a ton out there. And most of the studies were pretty short-term in nature, because again, they're describing surgical complications. The number of surgeries, both in the US and across the world, is increasing. And transgender and gender diverse people have been described in the literature as receiving health care at, quote, the margins of society. That's terrible. That is something that none of us should be okay with. And because of that, they're potentially at risk for higher levels of disability, pain, other types of dysfunctions, because they're not getting the same level of care that they could be getting, and compared to cisgendered people who are having similar types of surgeries. So again, my background is in cancer rehab and pelvic health. Let's think about the types of issues that we may see in patients following different types of surgeries for cancer, for example. So we know that people have mastectomies, they can have issues with persistent shoulder pain, chest pain, lymphedema, tumors of the pelvic region, incontinence, impotence, pelvic pain, sexual dysfunction, people that have surgery for head and neck cancer, lymphedema, facial pain, neck and shoulder pain. So we know, even though these surgeries are not the same, and a mastectomy is different from a reduction mammoplasty, but they're similar, and they involve tissue, right? So we would expect that people who are undergoing surgeries that involve the soft tissues, the muscles, may have issues that put them at risk for pain and disability after these surgeries. And so we know that these issues persist in cisgender individuals. So we were interested to see, well, we know that these issues exist in cisgender people. What about people undergoing gender-confirming surgeries? What do their outcomes look like in terms of musculoskeletal pain and pelvic floor dysfunction? Are they getting the care that they need? Are they aware that care exists to address some of these issues that they may be having? And that's really the genesis of this information. The other thing to think about is the context of having a gender-confirming surgery or surgeries versus the context of a diagnosis like cancer. No one gets a diagnosis of cancer and says, yes, I get to have a resection, or I get to go through chemo. It's a devastating diagnosis, right? And so there's a lot of emotional and psychological context surrounding that experience versus the experience of undergoing a gender-confirming surgery. That's to confirm one's identity. That's a very different experience, one that participants have described to us as one that leaves them with hope for this life that they've wanted for themselves for a very long time. So very different contexts, and I think those contexts, we know this, context can play a big role in people's pain experience, how they perceive pain, how they manage it, how resilient they are, how they cope with things. And so that context is really important to think about as well. So then, what types of musculoskeletal pain and pelvic floor dysfunction do people report following gender-confirming surgery? Because there's so little literature about this, we couldn't really just jump into designing a pilot study and doing all this. So we decided we need to talk to people who've undergone these procedures in a relatively short period of time from when we started interviewing to see what issues did you have or do you remember having, how were those treated, who did you talk to, who did you get help from, et cetera, et cetera. So we applied for a grant from the Academy of Orthopedic Physical Therapy, which is a component of the American Physical Therapy Association. And we were looking at we proposed a two-phase project. The first phase was to conduct focus group interviews with individuals following gender-confirming surgery that had at least one procedure within the last 5 years, and then using the information from these focus groups to develop a larger scale survey that we could distribute to a more diverse and larger and geographically diverse sample of people who've undergone these surgeries. So we got the grant, I think it was 2019, and so we started planning to do things in 2020. Well, then COVID happened, and so our in-person interviews turned largely to Zoom interviews, which actually worked out fine. It was great. The interviews were recorded. We did not keep the video recording, but we did keep the audio, and we had those professionally transcribed. And then 2 investigators reviewed the transcripts, and we had deductive themes that arose from the interview questions that we asked people, and then inductive coding of new themes that emerged. So if there's any disagreement between the 2 investigators, who were reviewing these transcripts on the coding. I was the third investigator then that was the tiebreaker for that. And so this was a mixed method study. We had this was the qualitative portion of it. And then we also asked people on a demographic questionnaire just more information about what type of surgery that they had, age, pelvic pain, musculoskeletal pain, and other issues that they had leading up to surgery, the providers that they interacted with leading up to surgery and after surgery, and then also any barriers that they had. But really, keep in mind the goal of this was to get a sense of what types of muscle pain and pelvic floor dysfunction are they having after surgery. So we interviewed 23 individuals who underwent at least one procedure in the last 5 years. The average age was just under 28 years old, and the age range was from 20 to 70. We had 11 that identified as men, 9 as women, and 3 as non-binary. On average, people had 2 surgeries, but anywhere from 1 to 4 was the range reported. So the majority of our sample underwent a reduction mammoplasty, followed by a vaginoplasty, breast augmentation, phalloplasty, orchidectomy. You can read all the other surgeries on here. So we had a wide variety of surgical procedures that our participants underwent, the 23 people that we interviewed for this phase of the study. So what did they report to us in terms of their musculoskeletal pain and pelvic floor dysfunction? So 83% of people reported pain with movement following surgery, especially in that post-acute and post-acute phase following surgery. Over half reported low back pain, groin and hip pain, just under half reported chest pain, shoulder pain, and pelvic pain with 17%. Over a quarter reported urinary incontinence, over a third reported urinary urgency, and over half reported pain with intercourse. 3 people received rehab services prior to surgery, and all 3, those rehab services were related to physical therapy. And then 7 received rehab services after surgery. I think it was 3 that had PT, 4 that had PT, and then 3 that had occupational therapy afterwards. Now, again, our goal as pain researchers, physiotherapists, we were interested in pain, pelvic floor dysfunction. The themes that from the interviews, however, the themes that you see up, those 3 themes up top in bold, those are the things that participants actually chose to speak about. That's what they spent their time in these interviews discussing. So these are like the major themes that actually emerged from these interviews. Also that emerged, but again, not as heavily emphasized by our participants, were impact of treatment, types of pain, musculoskeletal dysfunction, and pre- and post-surgical assessment. But again, participants really were most interested in discussing the barriers to care, their satisfaction with care, and then also their social support. And so what I'm going to share now is some of the quotes that our participants shared with us related to barriers to surgery. And so one of the questions that we asked them was, what was the amount of time between when you decided you wanted to have surgery versus when you actually had surgery? Was this time longer or shorter than you expected? If people said it was longer than I expected or what I wanted, we asked them why. Was it difficulty? Was it finances? Was it finding a surgeon? What were the reasons? And so barriers to surgery, financial and insurance issues were a huge barrier to a lot of our participants. And then access to information about surgery and recovery. It was pretty wild that many of our participants reported that they got most of the information about how to prepare for surgery and what to expect after surgery from Reddit. So, thankfully, we have this online platform that exists where you have a community of people providing support and information to individuals undergoing these procedures. But what a sad state for our healthcare system that patients have to resort to Reddit to get information about how to prepare for these major surgeries and how to care for themselves after these surgeries. So this quote is from one of our participants, and this is this individual was a physical therapist. So this is someone that's an important point to make, because this is someone who is acutely aware and intimately aware of how convoluted our healthcare system is, and the authorization process and referral process and getting signatures and all of that stuff that goes along with being a physio in the States. And this is what they said: let's leave gender affirmation out of it. I think our providers do a terrible job of facilitating between us and our insurance companies. There's very little disclosure, honest disclosure, between providers and insurance and the actual patient themselves. The patient bears the burden of understanding, and they're in charge of calling the insurance company and dealing with these things. And this individual actually, told us that they weren't sure that they were going to have surgery. I mean, it was up until the day or the week before or the week of that they were dealing with the insurance company and the surgeon's office and trying to get information, trying to get these approvals together. So it's just for someone to have that level of knowledge and know how to get answers in the health system and to still have these challenges was really discouraging to hear. Another individual said, now we have profiling in the community, and profiling doesn't just happen once and it stops. It's something that's built upon and upon. You find people body shaming, people trash talking, and at times it may take a toll on a person. The profiling and utter discrimination was another barrier. What about satisfaction with care? So people talked largely about the communication with their healthcare providers, the use of LGBTQI plus terminology and pronoun usage. And what we found was that in general, there was varying levels of satisfaction, but in general, people were satisfied and no participants expressed regret about undergoing these procedures. This individual said, my surgeons were super responsive. I know that sometimes I'm emailing them super early or super late, and they've been very responsive with my concerns and very quick to, like, if we need to hop on a call, we can hop on a call or a video chat to see something, we can do that. They're also fine with me sending a ton of pictures. So that was really great. This person, and this is what I spoke to earlier when I was talking about the masculinizing or feminizing procedures. They said, I'm non-binary, and I guess they assume that everybody having the surgery is going female to male. The nurse was talking to my mom about what to do, and the post-op nurse was using he, him pronouns. It definitely woke me up out of the anesthesia or whatever, because that just felt weird to me because I don't identify as that. Social support. This was an important topic from our participants as well. So, and this is something that they said was essential to recovery, and again, many of them didn't know that they needed the support that they needed until they consulted an online community. My family was very supportive. I was able to adjust to the situation quickly, but that took me around 1 month for me to heal. I'd given my job a sick notice of around 2 weeks, but I went on having the pain for 1 month, and that was quite difficult for me to explain. Not everybody is pro-LGBTQ at my work, so that was another issue. Having to explain that the reason I am sick is because I underwent a procedure to help me transition. Bless my mom for being a true brick. I absolutely needed someone else to change my bandages because it's gnarly. I think sometimes that leads to worse outcomes if you don't have someone who's not squeamish about those things. It's super painful and awful, and I don't want to do it, but really you need to change it like twice a day. And so very much relying on another person to get you through it. The next theme that emerged was the types of pain. And again, this was primarily focused on muscle pain. So there's a deep amount of muscle and knee pain that came along with it, as well as groin pain as well. That entire area is just pain most of the time. I would say we're almost officially a year out from the surgery date, and I still have muscle and knee pain. Pain which was present maybe during sex, so during climax, because during penetration and stuff, I didn't have any pain, but I think it was the body maybe trying to get used to the new body. And again, this next quote goes to context. I felt awesome after surgery. I was so freaking happy to look down and not see breasts. I probably had lots of pain and didn't even think about it, to be honest. So in terms of post-surgical care and the impact of treatment, I didn't start pursuing physical therapy until those wounds were closed. I wasn't comfortable trying to do that beforehand. I wish I had, though, honestly. I think some of the pains that I experienced could have been mitigated and not have gotten as bad as they did. I also just didn't know. I was telling my surgeon, oh, this is still pretty swollen. And he was like, that's normal. That's pretty normal for things to be swollen. It'll go down. But really, it wasn't a normal kind of swelling. It was a swelling that needed help with lymphatic massage and decongestive therapies in order to actually help resolve itself. I see that physical therapist / lymphatic doctor about once every 2 weeks now. This is a really important topic for me and my community because I think there's an extreme lack of access to care, particularly around gender affirmation in general, but particularly with physical therapy. I think that if we could get the word out there that yes, indeed, physical therapists know what they're doing and we could really improve your outcomes. We ended each interview with asking the participants, acknowledging that we are researchers, but also clinicians, what do we need to know about? What do we need to know about, study more about, to improve your experiences as someone who's undergoing or who has undergone gender-confirming surgery so that people in the future have better access to care than some of you may have had. And so the number one thing was increased education for patients going into surgery. This was above and beyond. People didn't feel like they were well informed and that the information that they got, while they were grateful to have received this from their online communities, coming from their surgeon or other healthcare providers with whom they were interacting would have been more helpful. So what types of help are they going to need after surgery? What could they be doing to prepare for surgery? And then also, what should they expect in terms of recovery post-surgery? The other suggestion was for improved provider awareness and knowledge of working with transgender or gender diverse individuals. So using a patient's pronouns and their name, avoiding the use of a dead name and misgendering. So we actually had a dead name is a name that was assigned or given to someone at birth, and that's not a name that the individual uses post-surgery. So the dead name is not one that typically people don't ever want repeated or said out loud. We had a participant who had participated in a study at UF prior to their transition. And UF, like many other institutions, you have to get participants' social security numbers in order to pay them to participate in these studies. And the social security number that this individual had was linked to their dead name. And so we put their social security number in the system to add them to the payment system, and their name was not coming up. It was their dead name. And this was this was clearly distressful for the participant. So we didn't say the name out loud. We didn't even show the participant, the name in the system to confirm. And it was this distressful. So imagine being a patient in a clinic or, waiting somewhere, and your healthcare provider uses the participant's or the patient's dead name because they didn't look at the intake form that the patient just filled out. They were relying solely on the medical record or the history that they saw on the computer. Sometimes these things aren't updated in the way that they need to be and at the in an efficient manner. And so making sure that you're looking at the intake form that your patients are filling out, making sure that the name that they have on there is what you use to refer to them as. And I think this was a common theme as well, is just ask. If you're not sure, ask the patient in front of you. Don't make assumptions, don't presume things. Our participants said they would much like much prefer to be asked about what their pronouns are, what their name is, versus someone making an assumption. And again, not relying solely on the medical record to obtain this information. So phase 1, summary of outcomes, the biggest barrier to surgery was financial. Post-incisional pain and musculoskeletal pain were common. Pelvic floor dysfunction, including incontinence and sexual dysfunction, sexual pain was also common. But again, despite these issues, overall, patients were highly satisfied with their care and did not have any regrets about undergoing their surgery or surgeries. And this lack of regret is consistent with previous work in this area, which shows in general people are satisfied with the care that they receive and lack of regret following these procedures. So that's great. We have 23 people who gave us really good, strong information, but now we needed to see how does this look in a larger sample of people? So how prevalent are pain and pelvic floor dysfunction in a bigger and more geographically diverse sample of individuals post-surgery? So we used, I guess I should back up. So no one on our team is transgender, right? And so we got a lot of great information from these individuals during these interviews, but to develop this larger scale survey, we felt strongly that we needed to get some other perspectives, specifically perspectives from transgender individuals about the survey. So we actually asked participants who participated in the interviews if any of them would be willing to review the draft survey ahead of time and just give us feedback on the language that we use, the clarity, the length, all those types of things. So 3 individuals actually agreed to do that. They gave us some feedback about some of the terminology that we use, some of the questions, and so then we built this survey. Our survey was in REDCap, so we collected demographic information, types of surgeries that they had, the types of care that they received, and then also issues related to muscle pain, movement pain, and pelvic floor dysfunction following surgery. Our research assistant sent out information and flyers about the survey to US-based LGBTQIA+ organizations. We kept the survey open for 3 months, and we capped our responses at 1,000 responses. So has anyone done survey research before? It's fun, isn't it? We had to do quite a bit of data cleaning and sort of checks to make sure that the data that we were receiving were in fact valid. So we had to enable the CAPTCHA function in REDCap. We had to collect IP addresses to make sure that there weren't multiple people at the same IP address filling information out. Anyone that completed a survey in less than 2 minutes, we eliminated or we didn't use their responses. And then we also had free text responses in the survey as well. And so sometimes people will just write the most random things in the free text. I mean, I think, please review my resume was one of the things that stuck out, So irrelevant free text responses, we also removed those people from the data set. So after all of the cleaning, 584 responses remained. And so of those, 118 people had undergone a phalloplasty, 89 had undergone a vaginoplasty, and 79 had undergone a reduction mammoplasty. Now, it's important to note that the way these data look now, it looks like individuals, it very well could have been that someone with the phalloplasty also underwent a reduction mammoplasty. And so the way that the survey was designed, people checked whatever surgery that they had, and then based on that, they were asked specific questions based on the surgery type. So it could have been that people had multiple surgeries that they underwent or that they reported undergoing with the survey. So what did we find in terms of areas of bodily pain post-surgery? So we looked at genital pain, pelvic pain, and hip and groin pain for people that underwent the bottom surgeries. And we compared actually phalloplasty and vaginoplasty, and the proportion of individuals between these two groups who reported genital, pelvic, and hip and groin pain did not differ statistically. People that underwent mammoplasty reported, over half reported chest pain, 14% reported genital pain, and 13% reported upper back pain. So again, not dissimilar from what we saw from our focus group data. These are still common areas of bodily pain after surgery. So treatment then for post-surgical pain. We asked people what kind of care did you receive after your surgery? So in general, most people receive care from their surgeon. That's very common. Post-operative surgical care and checkups or follow-ups were very common. But the persistent pain that remains, 70% did seek care following phalloplasty or vaginoplasty, but the majority of people sought this care from either their surgeon or their primary care physician. So only a fifth of these people were treated by a physical therapist. After mammoplasty, 78% sought care. Again, the majority of people sought care from their surgeon or primary care physician. 16% of these individuals were treated by a physical therapist, 8% by an occupational therapist. The majority of people reported that their pain did resolve at 3 months. So what about pelvic floor dysfunction in these groups then? So in the people that underwent a phalloplasty or vaginoplasty, almost a quarter reported incontinence. None of them received care from a physical therapist following surgery. 19% reported pain with intercourse, and 15% of people who had a vaginoplasty and 20% of people who had a phalloplasty received physical therapy for this pain following intercourse. So where do we go from here? Musculoskeletal pain and pelvic floor dysfunction are common issues following gender-confirming procedures. And these rates of pain and dysfunction that we're seeing are not dissimilar from their cisgendered peers who are undergoing these surgeries. And so one very important takeaway from these data is not that people who are undergoing gender-confirming surgeries, they should not be discouraged from undergoing these surgeries because of pain or pelvic floor dysfunction. We would never tell someone with breast cancer not to have a mastectomy because, you might develop lymphedema or you might have shoulder pain or neck pain. We never tell someone undergoing a prostatectomy for prostate cancer, hey, you might become impotent or incontinent, no surgery for you. That's not what this means. All these data suggest and show is that these people have issues that are similar to their cisgendered peers, and they're not getting the same level of care. And we have to do better as healthcare providers and as healthcare providers that work in this larger healthcare system. This extends to our entry-level training programs. And so, if you are an educator, you work in academia, how many of the clinical examples or clinical case scenarios, or doesn't have to be in academia, you could be a clinical instructor in the clinic. How many case examples that you're presenting to your trainees involve people who are transgender or who are undergoing these procedures? So we have to think a little bit more thoughtfully and inclusively. If we really want to be inclusive, we have to make sure that these individuals are represented in our clinical training programs. What systems can we put into place to address these gaps in care, particularly from a pre- and post-surgical perspective? So if you work in cancer rehabilitation, you may be familiar with the prospective surveillance model of care, which in that model, you're not waiting for someone to come in with shoulder pain or lymphedema following a mastectomy for breast cancer. You know that someone is going to be having a mastectomy for breast cancer, so you prospectively address the issues that they may be having. You spend the time, you take the time to educate them, to meet with them, to show them the exercises that they could be doing, what warning signs to look out for in case of lymphedema. So it's a prospective model of care versus a reactive model of care, waiting for someone to come to you with issues, or go to their surgeon or primary care physician and say, I've got incontinence, or I've got pain with intercourse now after surgery, I don't know what to do with it. Physical rehabilitation, I mean, obviously this is my bias. I'm a physical therapist. That's really what led me to think about this project and, do this study. We need to be doing more. And I'm a pelvic health physical therapist, and I will say pelvic health PTs really helped pave the way for gender confirming care in the scope of rehab. But when we first applied for this grant, I had several colleagues, my PT colleagues, that kind of, I would say chided, but definitely said, why are you applying for this grant from the Ortho Academy? Why wouldn't you apply for a grant from the Pelvic Health Academy? And I said, pelvic health PTs are pretty well aware of these issues in this patient population. Y'all are the ones that really need to come up to speed with this. That's why. And it was a very intentional decision to apply from the Orthopedic Academy, because this is not a conversation that physical therapists who typically work in outpatient orthopedics are used to having or used to hearing about. And so, again, this is not just about care for individuals undergoing gender confirming care living in a certain piece or practice area of physical therapy. As rehab providers, we all need to be aware of the issues that these patients may face and that they may present to us with in the clinic. Virtual care, I think COVID has definitely demonstrated that there are many ways to provide care virtually. So it shouldn't be a limitation necessarily that you're not physically around someone or not part of a big health system or healthcare team that does these procedures. There are ways to provide care virtually as well. So the other thing that I think is important is, what are we doing to create inclusive clinical environments, academic environments, and also research environments? And so one of the first and obvious things is having a gender neutral restroom in your clinic, in your school, whatever it is. I mean, that's the first thing. I think, really that's an important one. Asking about sex and gender identity on your intake forms. These words, even 20 plus years after the Institute on Medicine defined those terms and recommended that in research, these things be viewed as distinct and separate and researched separately, people still use these terms interchangeably, and they are different. And they're different for important reasons, and we need to understand that. Asking for research participant or patient pronouns. One of the recommendations that one of the three individuals that gave us feedback on that survey, one of the things that they said, we had on the survey, what are your preferred pronouns? And they said, take the word preferred out of there. The pronouns that I use are not a preference. They are who I am. And so it's not I'm going to have, a steak on Tuesday, but I prefer fish on Friday or something like that. It doesn't change. It is who I am, and this is how I want to be called. And so it's not a preference. It is. That's it. Training for staff, particularly related to some of the things that we already discussed about making sure that you're reading the intake form that a patient completes, or an intake form that a research participant fills out. And I think the other thing is, consider sharing your own pronouns. And why is this important? I was having this discussion. I'm gonna call it a debate, because it really was a debate, with an older male family member. are. And, he's a healthcare provider, and he said, I don't understand. I think he saw my email signature. I'd sent him an email from my work email, and he saw that I had, she, her as part of my signature. And the next time I saw him, he said, so what's the deal with these pronouns? Is it a fad? What? I don't get it. Why do people care what my pronouns are? Why do I have to, why is everyone doing this, essentially? And I said, take a step back. It's not really about you, right? Like, yes, my pronouns are important. This is how I would like you to refer to me. But really, when you put your pronouns out there, whether it's in a talk or on your email signature or on your clinic website, whatever it is, what you're doing is sending a message, an important message, that pronouns matter, that you, as the healthcare provider, the researcher, are not in a position to make assumptions or presumptions about someone based on how they look or how you would assume who they are. And so it sends an important message that pronouns matter, that you acknowledge and are aware of, that gender identity doesn't always match biologic sex, and that's okay. And it's important to acknowledge that, and that you are included. You're there, you belong there, and that this is a safe space for you. And so that message is really what's important. It has little to do with us putting our pronouns out there as much as it does with the environment that we are creating and the message that we are sending to people who may come across us. So this is, without a doubt, an underserved and under-researched patient population. These two small studies really are just the tip of what we need to be looking at. And, I challenge everyone in the room today, listening online, how can you educate yourself and your colleagues in caring for transgender individuals, both as patients and people who participate in our research studies, and emphasizing that inclusivity in your labs, in your clinics, in your training programs. You can emphasize this in small but really meaningful ways. And again, it's not about us. These are generally very small gestures that we, in relatively speaking, places of power, right? There exists a power differential between a clinical provider and a patient, but things that we can do to create a welcoming and safe environment for all of our patients. I really, really want to thank all of the participants, especially those who participated in the focus groups and really shared some important personal, intimate information about their healthcare experiences, and the outcomes and issues that some of them were still having at the time of the interviews. I also want to acknowledge the other members of the study team: Nicole Stetton, Brown University, Harvey Chim in the plastic surgery department at UF, Mark Bishop, who's in the PT department with me at UF, Adriana Rivas, who's our research assistant and pre-med student at UF, and then Alex Hill is a collaborator and friend at University of Florida Health in Jacksonville. And finally, also the Academy of Orthopedic Physical Therapy for funding this really important work. So thank you, and I'm happy to answer any questions. And I think I'm right on time.
All right, thank you. Amazing as always. Any questions?
It sounded a bit in the beginning of the call, beginning of talk, that the same way we put patient advocates into cancer centers or other places like that, that a patient advocate could be in somehow
Yes.
These centers. And then I had a question as to whether the patient ends up handling all of the healthcare forms because, one, doctors hate dealing with insurance, and so they've all stopped dealing with it. Two, this is a different form. They don't know how to fill it out, so they don't know how to navigate it, and they don't have somebody to do it. Or is there somebody that could be an ideal point person to navigate those as to how are these
All of the
possibilities?
All of the above for the second question. I mean, absolutely. I think all of those come into play. I think, and related to that, and to answer your first question, what we found is that with the exception, there were maybe 2 participants that I can recall, and I said it on every interview except for one, but 2 participants were truly part of a transgender medicine team where they had, the care was comprehensive. The healthcare providers communicated with each other prior to surgery, immediately after surgery, in the post-acute and subacute phase and post-surgical phase, all phases of post-surgery. But the majority of people, their care was very disjointed, okay? So they had to find a surgeon. A lot of our participants were seeing a counselor, whether it was a psychiatrist or clinical and health psychologist, leading up to surgery. But all of them were required to have a consult with a mental health provider prior to surgery. This is a requirement to be, Not all those people continued to see that provider after surgery because it was a checkbox that needed to be done, prior to surgery. The 2 people that had access to rehab providers, specifically PT, prior to surgery and after surgery, they were the ones that really felt supported, and that I have a team of people that's taking care of me, and that, yes, I still have to advocate for myself, but I know that I have people who are looking out for me. Whereas other people really had to advocate for themselves every step of the way, whether it was insurance, whether it was getting care for pelvic pain or lymphedema or knee pain, the level of advocacy that patients had to perform seemed to vary based on how cohesive of a healthcare team that they had for the surgery.
Okay, as you were speaking there, a second question came up, or idea. What was the size of the healthcare systems they were dealing with, such as, was this in more rural settings, larger settings, mid-level city settings, and that kind of overarch?
The ones that had access to a really cohesive team, comprehensive team, were at large academic health centers. So it was the people that had to travel to have the surgery, and then they may have stayed there for a short period of time so that they could follow up with their surgeon after surgery, but then they have to go home. And so then they still have incontinence, or they still have pain, or they have difficulty walking, and now it's, okay, well, who do I go to? Do I contact my surgeon because that's the person who did my surgery? Do I try to find a PT? Is a PT the person that I should be seeing? And that's why I say the care was disjointed. It just wasn't, it's not a smooth experience. And it's very, for patients that are, undergoing cancer treatment, typically they're getting care from a team of people that are highly involved at every level of treatment. And that's just not the same for the people that participated in the study, and for the majority of our participants.
You saw a difference between academic facilities and rural healthcare?
Yes, academic facilities that had the resources in place to have those teams in place.
Do we see differences in healthcare between men transitioning to women versus women transitioning to men, or we just kind of crap across the board?
We didn't see big differences in care. I think I'll go back to, we didn't see big, the sample sizes, for this, to have 20% treated by PT, there wasn't a big difference between them. In general, it just not a lot of access to care. And I shouldn't, I don't know if I should actually say access, if that's the right word, or knowing to go to a physical therapist, being recommended that they go to a physical therapist or an occupational therapist. So, I think my professional opinion would just say it's crap across the board.
A couple questions from online. The first one was, in the very beginning, where'd it go? Said you noted the term gender affirming versus confirming care. Mm-hmm. Was there a reason you chose one word over the other?
Yes, so this was actually another piece of feedback that one of those 3 participants who reviewed the survey recommended. In all of our focus group materials, we had used gender affirming surgery and confirming surgery. So if you look at the terms affirmation versus confirmation, an affirmation is something that you do or you say to convince yourself or validate yourself of something, whereas a confirmation is like the final, the ending, this is it. You're not trying to convince oneself of anything. And so confirmation, how it was explained was it's a stronger word and one that is not to where you're trying to convince someone. It is what it is, and this is what I'm doing.
Hi, thanks for a great talk and for all your amazing work. My question is about if there's any best practices you could point us to for use or changing from use of the dead name and past pronouns, and particularly related to EMR and records that are speaking to the past.
Yeah, so I think the biggest thing is having patients fill out an intake form, including on that, not just having them fill out what their name is, but also what their pronouns are, any surgeries that they've had in the past. I think as a healthcare provider, if you have an EMR and you know that this patient is coming in, those surgeries should be listed, ideally, right, in their EMR. And so just making sure that you're aware of that. And once you see that this person's had a phalloplasty or a vaginoplasty or a reduction mammoplasty, whatever the surgery, may have been, making sure that something should trigger, okay, this is someone who underwent a gender-confirming surgery. Let me make sure that the name that I have in this medical record actually matches the name that they've put on their intake form. And so I think giving patients an opportunity to put their name down, write their name down, type their name in, whatever, as opposed to assuming that the medical record was correct. And honestly, I would not have even thought about that had we not had that incident with the payment with that one participant. And I did not, again, this is my bias as a cisgender person, I did not know that saying that individual's dead name would be so distressful. And thankfully, one of our co-investigators is in the room, and she jumped right in. Nicole jumped right in, and she said, "Don't worry about it. You don't have to confirm. We're not going to say the name. We're not going to do any of that. We'll do what we need to do to make sure that this is corrected with human subjects payments." But I think giving people an opportunity to share that information is probably the most important thing.
Thank you for your presentation. I think it's really confronting for lots of us to see that there are such plain examples of neglect for humans in our community. I guess it's not one part's a question, another part for anyone in the room who's interested. So in the state where I live in Australia, we have an organisation called ACON, and out of that they've developed a program called Pride in Health and Wellbeing. Allied health and medical practices can access that program, and it's full of resources, including what's called a Health and Wellbeing Equity Index. And so if you go to prideinhealthandwellbeing.com.au, you can download that inventory and you can use it to appraise your practice like it's for the Australian setting. So my question out of that is there anything kind of remotely like that or applicable within the American context? Because the thing that I found most valuable is, and working with this organisation, is like you found through this co-design process, nothing about us without us. And as someone who's not, doesn't have a lived experience of what it's like to be part of that community, what specific resources beyond everything you've shared with us here?
So, thank you for the question. The one resource that I'm aware about, and again, my bias is PT. So the American PT Association in their Academy of Leadership and Intervention has a special interest group called PT Proud. That has resources, again, primarily geared towards rehab providers, but they also have a directory of physical therapists who have experience working with members of the LGBTQ plus community as well. So, I mean, some people have asked in the past, how do I know who's going to be a safe provider for me? Who can I go to that I trust? And so that's one of the online directories of providers that I'd recommend.
So from online, kind of looking for a little more of a specific kind of language example here, but what might be a respectful conversation between a clinician and a patient look like when the patient has had top surgery and they are exploring issues of pain, limited movement, and or range of motion? So kind of just looking for a little bit of practical example.
In terms of asking the patient about their...
Like what that conversation might look like as far as like being appropriate and respectful, but getting to the point of things.
It would not look any different than any other patient that'd be coming into your clinic that had, a mastectomy or rotator cuff surgery. I think being aware of who the patient is, their name, their pronouns, educating yourself on what some of the common issues are following these surgeries is important. But in terms of the care that you're providing, what you're doing as a rehab provider, that shouldn't change. Just like the care that we provide to pregnant patients with back pain in general is not that different than the care that we provide to patients who aren't pregnant, who have back pain. And so I think there's sometimes, and I have quite a bit of experience with this actually, just as someone who worked in cancer rehab, and a question that I would get asked often is, well, what do I do about this? This patient's come in, they've got breast cancer, but they've also got shoulder pain. What do I do with them? And it's like, what would you do with anyone else? Yes, they have cancer, and there are some things that may need to be considered for someone that's in active cancer treatment. But in general, the care that you provide is going to be very, very similar. They're humans, right? They have muscles, they have bones, they have ligaments, they have tendons. So it's a human. Treat them like you would any other human.
Fabulous talk, Meryl. Thank you. Do you have any idea of what percentage of EMRs accommodate for pronouns?
I don't. I think that would be very specific to the health system. Yeah, I'm not sure.
I feel like that's kind of a flat note to end on, but well, actually, I could wrap that up a little bit. So I think Sandy was asking because we've struggled when we had entropy, and I struggle in the current clinic I'm in. So I think following Meryl's advice of just, you have to look, right? So you have to do a check. Unfortunately, we don't have paper records anymore. It would have been a Post-it note or something that would be easily in your face. It's not anymore. So you're going to have to be an exceptionally caring human and pay attention. Okay, well, another round of applause, though. Thank you for doing this important work.